The unknown. Yeah, yeah, that's a good, always a good thing to remember.
All right. Go ahead. Great. So I'm delighted to introduce Professor Amy Kupstinski as part of our ongoing Davis Lecture Series focused on the financialization of health. Professor Kupstinski is an internationally recognized scholar whose work has ushered in a new frontier of scholarship and activism centered on law and political economy. She co-founded the famous Law and Political Economy blog, which houses the Law and Political Economy Project, a network of scholars, practitioners, and students working to develop innovative intellectual, pedagogical, and political interventions to advance the study of political economy in law. In addition to this work, she also co-directs Yale's study of political economy and law. She also co-directs the Yale Global Health Justice Partnership and has decades of experience working in the HIV/AIDS and global treatment access movement, working with groups like ACT UP and the Treatment Action Campaign. As a student at Yale Law, she helped push Yale and one of the world's largest drug makers to forego some patient protections for AIDS medicine, making the drug more affordable in South Africa. So I really think it's fair to say Professor Kupstinski is a real trailblazer and is doing some of the most pioneering work to help legal scholars, activists, and policymakers better understand how law mediates the reflexive relationship between politics and the economy. She currently is Professor of Law at Yale Law School, where she was recently awarded the Faculty and Staff Excellence Award in recognition for her outstanding service to her university's community. And prior to joining Yale in 2012, she taught at the University of California, Berkeley School of Law, and prior to that, Professor Kupstinski served as a law clerk to both Justice Sandra Day O'Connor and Stephen Breyer at the US Supreme Court. So please join me in welcoming Professor Kupstinski, and I'm really delighted that we'll all have the opportunity to hear from her. Thank you.
So thanks so much for inviting me and putting together this terrific series. I did have the chance to watch a little bit of some of the earlier presentations online, and I love the fact that you can go and see the other presentations. It's really a terrific group of people and such an important topic. So as I thought about what my contribution might best be, you know, I'm a legal scholar, as Joe mentioned, and I work substantially on the pharmaceutical industry. And some of my most formative learning experiences were, in fact, and Joe mentioned some of this, as a young student working with movement activists around the world to try to bring the prices of HIV/AIDS drugs down. And ultimately, that movement had really astonishing successes. It did help to make possible programs to treat HIV in many countries, particularly in sub-Saharan Africa, where previously there had been no treatment. So really millions and millions of people who benefited from those campaigns and organizing efforts. I became a legal academic, of course, and a lot of my work has been in the last 5 years developing law and political economy as an approach to how to think about legal scholarship and legal sort of policy making and legal interpretation. But I want to sort of talk about today is the story about those early beginnings, how it led me to work on the intellectual frameworks that I'm now working on. And then at sort of in the second half or towards the end, try to think about what the work we're doing around law and political economy might have to suggest about what work on political economy and health could incorporate and look like. So one of the things that's been very gratifying for me is that over these last couple of years, law and political economy frameworks, or LPE as we call them, has really taken hold in the legal academy. People talk about it with a lot of excitement. People read our blog. It's routinely kind of talked about as a new school of thought in legal areas. And there's a kind of an organizing spirit to it. We have student groups at more than 30 campuses and lots of events and so forth. I encourage you to check them out if they're of interest to you. But I think there's people who asked me over and over again, what, is there something called political economy of health, and like, what would it mean to take some of the ideas you're working with and think about them here? So this is a great chance for me to be able to do that. And so some of the ideas that we're working on law and political economy have also really helped shape the policy debate. For example, broadly, we talk about challenging corporate power and building a more democratic economy. But in my area, we've seen some really notable changes over the last couple of years. And that's in part, I think, shaped by people who are doing this work on law and political economy. So whether that's the passage of the first drug pricing law that we have in the United States, which is part of the Inflation Reduction Act, California's commitment to make its own CalRx brand of insulin and other products, the development of something called ARPA-H, which is an agency in Washington that's devoted not just to supporting early stage research in the biomedical sciences, but late stage translational research. So bringing more public funding to the full suite and sort of working toward what I would call a public option for biomedical R&D. So an alternative to the sort of public inputs, private control model of pharmaceutical development that we now have. I think there's reason to think that the kind of work that you're starting to do here around political economy and financialization can really have a significant impact on the world. And I think that's in a way our highest calling as academics, is not just to do our research, but to do research that can really affect the world. So let me start by taking us back to where I feel like I first really learned about that relationship between ideas about the economy and how the economy is structured, and both law and health. And that is back in 1999. I first learned about HIV/AIDS issues working for an organization when I was just fresh I'd done a master's degree in England. I was working for an organization called the London HIV/AIDS Providers Organization. And I was an eager young administrator, and I was writing updates for all of our members, many member organizations in London, about what it meant that treatment was now available for people living with HIV. Because this was 1999, and really the sort of effective treatments for HIV started in 1996. That's when we figured out that the sort of triple combination therapies could, in fact, transform HIV from an inevitably fatal disease to a sort of chronic illness. And so many people were going back to work and dealing with questions like, how do you go back to work after you thought that you had a terminal illness? But at the same time, I was writing reports about what was going on elsewhere in the world. And this was really the moment where I learned, as I think many people were learning at the time, that this transformational moment where people in the North had access to these medicines that were transforming their lives and totally changing the curve, making HIV no longer a death sentence, that these drugs simply weren't available in the global South. And I think, like many others, I had assumed at that time, these were new drugs. They were really sophisticated. They were probably really expensive to make. And that was probably, some part of the reason. It was really AIDS activists that figured out that that wasn't true. That in fact, these drugs could be made available much, much cheaper. It wasn't the cost of production. It was fundamentally the fact that companies held patents, and patents allow you to prevent anybody else from selling a drug. They're effectively a kind of monopoly, right? And companies held patents in places like South Africa and were refusing to allow generic drugs to be sold. So refusing to allow, in some sense, market competition to drive the prices of medicines down. And the consequences of this were really staggering, right? So HIV drugs at the time cost about $10,000 to $15,000 per person per year. And that was true in the US, and it was also true in places like Guatemala or South Africa. You didn't see huge discounts. And that's because they were being sold by originator firms who found it profit maximizing to price at the very top of the market. Why was that? Well, because even if you priced at the cost of production, it would have been hard for many ordinary people to afford those medicines. We had to end up building programs to actually provide real access to these drugs. But it was actually profit maximizing because there were a very small number of rich people who could actually afford to pay for those drugs. And that was the best way for them to make money. And so that's what they did. So companies, under a lot of pressure from AIDS activists and coalitions that were building in many different countries at the time, made a few concessions, started to sort of offer discounts, but they were inadequate. And I think the perspective that I developed at the time about this was that if it wasn't in the company's interests, that they weren't likely to make more systematic, bring the price down to the cost of production, which is what we needed from a public health standpoint. It was not going to be possible to build programs to serve literally millions and millions of people. You have a country like South Africa at the time, 1 in 5 adults with HIV, right? You're talking about building massive programs, and it was not a question of a 50% discount. We needed the drugs to be what we thought they could be. So instead of $10,000 to $15,000, $100. And today they're sold for less than that. And that's the difference between generic prices and the kind of patented prices of these drugs. So this was a really profound moment. Those old people in the room like me will probably remember that HIV was on the front page of the New York Times every day because of the really profoundly high rates of HIV in many parts of the world, and this sort of cataclysmic problem that we had drugs that could work, but that couldn't be prescribed. Some people said, the drugs are where the patients are not, because 90% of the world, people living with HIV were living in the South. We had the drugs. Why do we have the drugs in the first place? Because there were people in the North. There was profits in the North, but we also had them because of a lot of public funding. And so the formative lessons I learned in this period are ones that I've carried through my work, and I'm happy to talk more about, and I will talk a little bit more about today, but was these products, which came very substantially from public funding, had been handed off to industry. Industry has patents, and they chose to use those patents to raise the prices of drugs. They were very, very fiercely defending their patents at the time, even in South Africa, right? In a place where you had an unbelievable, funeral homes open 24 hours a day. And they, in fact, were suing, the sort of Pharma Manufacturing Association was suing Nelson Mandela because he was the head of the South African government at the time, and the South African government was trying to use a law that it had on the books to, in fact, say, well, I know you have patents, but we can override them. That's our right as a government, and we can bring in generics. They were going to be from India, because they produce a lot of generic medicines there, and pay you a royalty. And in fact, they had a good argument that they had the right to do this, but pharma sued them, saying it violates your constitution, and was really pushing the U.S. government at the time. Al Gore was running for president, and he was threatening the South African government with actions at the World Trade Organization, saying you can't do this, you can't override these patents. There was enormous opposition to all of these ideas, and the part that that Joe mentioned, that I got to sort of be in the middle of, because I was going to be a student at Yale at that time. I started at Yale right at this moment in 2000. And Yale had the patent on one of these drugs. And it was one of the first line, you needed 3 drugs for the first line, and one of them was D4T. It was a drug developed at Yale University by a scientist who I got into contact as we built this campaign, who really actually ended up writing an op-ed for the New York Times saying, I think this drug should be available to everybody, because the reason I'm here and not at a private company is I want to make my research available to the world. That was not the position that either Bristol Myers Squibb or Yale took at the matter. So working with groups like Treatment Action Campaign, ACT UP, and Doctors Without Borders, which had just built an Access to Medicine campaign, we put together a request to Yale to say, please give up the patent on this drug. We tomorrow could make the drugs cost 5% of what they cost by bringing in Indian generics and start to build out a treatment program. And that was really important at the time. MSF was the first to really try to build out a substantial treatment programs where they were doing it in Khayelitsha, a township outside of Cape Town. And they were doing it in part to demonstrate that this could be done, because there was a lot of, frankly, deeply sort of racist ideas that this couldn't be done, that people weren't going to be able to adhere to their treatment and so forth. So they really wanted to demonstrate this, and this was a key part, was sort of breaking the logjam and trying to show that, in fact, there were cheap drugs available, and stimulate governments to do more to try to bring these prices down and get political pressure on the companies and also the US government to back off and allow this to be done. We were, over a very short period of time, successful in getting Yale to change. First it said no, and then they changed their position and said that, in fact, they had agreed with Bristol Myers Squibb, who had given us exclusive license to their drug in South Africa, that they would allow generics to come into South Africa, and very shortly after that, that happened. And many, many things led to that moment. But to me, it was a profound learning experience. And there was a couple of really important things that I learned from it. One, that some of these parameters that we take for granted inside of schools of public policy, health, law, like, well, you know, is it cost effective to do this? Many people said it's not cost effective to create treatment programs in the global south because they assumed the costs of the medicines, because they didn't know. It took advocates to figure out that actually that was not a static constraint. That was something that was a part of a policy design and could be undone. The other part was that we had created global treaties. In the 1990s, the World Trade Organization was created, and one very key component of the World Trade Organization was a treaty on intellectual property that said that all countries had to allow patents for medicines, and patents lasted 20 years. It did not actually say that South Africa couldn't do what Nelson Mandela wanted to do and override patents. It in fact provided a pathway, but there was a lot of misinformation, and you would regularly read people saying in the press that this was not, you know, this was expropriation, this was stealing American intellectual property, that this was not legal. It was legal, but it actually took a lot of activists to sort of point this out. Even governments weren't aware of this or admitting it. But it made it much more difficult. And this system created in the 1990s meant that a country like South Africa had to jump through a lot of hoops and still face the potential for retaliation by the US government, which could, and at the time did, try to threaten them with various kinds of trade and, you know, aid consequences for taking these actions. I would say that this was my introduction to the world of sort of neoliberal law and policy. And that's a lot of what we kind of an entry point for what we talk about in the world of law and political economy. So what is neoliberalism, and why did we get things like the WTO at this point in history? And one way, if that term's not familiar, I don't know how much it's been used in this lecture series or how familiar it is to those of you in this room, but neoliberalism is often described as an economic ideology that kind of recommends freeing markets and getting government out of the way, sort of liberating entrepreneurial spirits and, for example, shrinking regulation, often shrinking the welfare state, undermining labor unions. Think Reagan, Thatcher, and the kind of Washington consensus, if those, the policies that the suite of policies adopted by these major sort of historical figures. But that way of defining neoliberalism is actually a little bit problematic, I think, because it takes as a given what I think is the sort of ideological framing, like we're going to free markets. And there's markets that are free and there's markets that are regulated. In fact, if you think about the story that I was telling you about what was going on in South Africa, you know, are patents free markets or are they market regulation? You know, South Africa was in a situation where they wanted to be able to buy, they wanted competition. They wanted to be able to buy these drugs that were more affordable. In fact, that was a position that, you know, most countries had previously in history had the choice. If you'd like to buy generics, go ahead, buy generics, right? There was no treaty structure that made that impossible, right? So another way, I think a better way to think about the general sort of policy consensus that emerged in the 80s and the 90s and that had deep implications on both things like the global international legal order and also our domestic policy was in fact a kind of a political ideology that sought to protect markets from democratic control, right? And to allow more profits and to re-regulate. So for example, to diminish the power of unions or to diminish the power of a Department of Health that wanted to, say, use generic drugs and give more power to, say, in this context, the pharmaceutical industry, to sort of extract more profit and enable more extraction from the economy for people at the top. So another third thing that I learned at this time is that people really didn't appreciate in the institution. I was at Yale Law School, And I remember the moment when I went and asked a professor of mine, he taught intellectual property, and I was learning all these things from activists, like, hey, there's this thing called a compulsory license, and the South African government can do this. They can, it's legal under the law, and like they can go and they can lower the prices, and this is like, sort of literally on the front page of the New York Times every day. And I had to knock several times on his office. I had the feeling he didn't really want to talk to me. And I went into his office and I was explaining to him this idea and sort of asking him what he knew about it. And he basically just gave me the same story that you might expect, probably a story that I myself had believed prior to really looking closely at these issues, which was, well, this would be counterproductive to do this because you're going to destroy the market and you're going to sort of kill the goose that lays the golden egg, and you have to let the market have its way. I heard this other places at Yale. The head of our tech transfer office, the man who had first opposed this and later come to accede to it, literally told me, we had a discussion some months later after Yale had done the right thing, and we had created a new organization called Universities Allied to Essential Medicines, trying to get universities in general to do this proactively. Tears streaming down his face, you are killing people. You are going to undermine incentives for innovation. And so there's like really profound form of ideology that was, I think, running its way through these elite institutions. I'm particularly glad to talk about this here because some of them were really born and cultivated in the University of Chicago, right? Ideas about why one had to accede to markets and had to, in fact, unfortunately, limit, who could have access to these drugs for the benefit of all. So Yale did the right thing. The drugs are much cheaper now. Millions of people are getting treatment. And guess what? We didn't kill innovation. So like, how is all that possible? Like, how could that be? They were things that I could have told you then. Yale's president at the time came back and told me, again, years later, we had the chance to have a conversation. He told me that this is one of the things he was most proud of having done as university president. He's an economist. I said, how much did it cost you? He said, oh, I actually went and looked. Yale made a couple $1,000s a year in royalties in South Africa, right? Well, why is that? Because they weren't selling very much of this drug, right? And in fact, the whole world's market for HIV drugs outside of rich countries is tiny. We in the US are a huge part of the global pharmaceutical kind of market. And in the global south, all of sub-Saharan Africa is 1% to 2% of the world's pharmaceutical market. So you could really just write these countries off, forget about incentives coming from these countries, and allow them to have access, right? With really no consequences for innovation at all. And in fact, one of the problems that activists came to see was that if you relied on the market to drive innovation into, say, diseases that particularly affected a country like South Africa, you weren't going to get drugs. Why not? Because there's not enough money in it. It's expensive to develop drugs. We have HIV drugs, as I said, because the government invested very substantially and there was a profit center in the north. But if you look at neglected diseases from malaria to tuberculosis, like we hadn't gotten new innovation in those areas for decades. And we've only started to do that by driving a lot of public resources, in fact, into development through PDPs and governments and so forth, right? So all of that is to sort of, in a way, set the stage, right? For why I think it's so useful for those of us who are in academic institutions to try to understand sort of what is the ideology of markets? What are the institutions that structure markets? And how does that come to impact health? How can we also imagine alternative ways to do things? Because the institutions that we sit in can play a really powerful role in either constructing this, and defending the sort of status quo or in changing it. So, these neoliberal ideas about liberating markets and so forth, they came from academics. Really important thinkers like Friedrich Hayek and the Mont Pelerin Society. If you're interested in reading about neoliberalism, there's great histories of the development of this kind of thought. And you will get to the part where they talk about Milton Friedman and the Chicago School and the role of Chicago in particular as a place where these kinds of ideas were developed. You should check out Quinn Slobodian's book called Globalists, where he writes about the more European version of neoliberalism and how much it was a reaction to decolonialism. And in fact, that there was a sort of deliberate, when I was describing the WTO and this sort of idea of shaping the world trading order so that you could empower business and disable domestic constituencies from doing something like, well, let's make generic drugs available, or let's actually take that, that mine and nationalize it, right? And nationalize the benefits of that mine. The WTO was created out of an impulse very deliberately in the post-colonial moment to, in fact, protect capital against democracy. And so these are powerful stories that are very fundamentally about a bunch of academics, often with a tight nexus to sort of policymaking, who had ideas that had a big impact. And so part of why I became a legal scholar was out of recognition that the kinds of ideas and research that we do in these contexts really matters. In fact, some of my friends who did work on HIV told me that they thought, like, if I could get a job, you know, in a law school, that was the work that I could do that would be important to the movement that I was involved in around medicines. So I have continued to then work on these questions. And I will say that although in some ways the story I'm telling you is begin with is a story of success and sort of a sense that we can make a difference, if you fast forward to today, you will see still many fairly deep endemic problems with global access to medicines, with the frameworks that we have. So sort of HIV was in a way carved out, an exception was made, and we did build programs to deliver medicines to many people. But when you look at the COVID vaccine situation, if you look closely, you will see that the vaccines that we had here in the United States, the mRNA vaccines, were made available almost nowhere else in the world, that the US government subsidized to the tune of tens of billions of dollars, the development of those vaccines, and did not insist that the companies actually share the technology and enable manufacturing of those vaccines and enable other people to get access to those vaccines around the world. We have extremely high prices for medicines in the United States, and a lot of my work has now moved to work on the pricing of medicines in the US. So in New Haven, where I live, you know, a colleague of mine did a study about insulin and insulin rationing and found that 1 in 4 of her patients was not taking their insulin as recommended because they just couldn't afford the copays. Insulin is a drug that's quite old. There are slightly more modern forms called analog insulins, but one of the things that happened in the United States is, as has been true in a lot of areas, but you know, we've seen very, very significant price increases, right, over the last many years. And insulin is a drug that has gotten a lot of attention because it's so widely needed. There's so many people, if you have type 1 diabetes, you need insulin to live. And if you, by the way, you ration your insulin, you can easily end up, you know, both grievously, affected yourself and with higher healthcare costs, to the system, right? And you can die. And there are many people in the US who have died from not being able to afford their insulin, often young people who are poorly insured and who have rationed their insulin in this way because of the cost. Insulin cost over about a decade went up 400%. Nothing new about the drug, right? So something fairly deeply problematic is structuring the drug industry. And while we've had, again, some successes like the recent passage of the Inflation Reduction Act and lots of, I think, new initiatives, I'm happy to talk more about some of them, there's still fairly fundamental problems in the structure of medicines today. I can come back to those in the Q&A, and I will make sure that we have some good time for that, because a lot of my work is about these very technical questions. How can we bring the cost of medicines down without undermining innovation? Can we actually make innovation work better? There's actually quite a lot of problems in the private sector innovation market, including not wanting to share data because it might disclose something that is unfortunate for your sales. So I've worked a lot on trying to get access to clinical trial data so that we can better understand the implications of medicines. There's Me Too drugs, so lots of piling on when we have a successful drug as opposed to investing and sort of getting like new, slightly different versions of it as opposed to investing in truly breakthrough research, which tends to be something that we get more from the NIH, right? So a lot of really important policy questions about how you can do this better. And I'm deeply invested in all of that, but rather than go there, I wanted to sort of then talk about this move to do more work on political economy and sort of what I think might a parallel sort of thinking about health and political economy might look like. Okay, so law and political economy scholarship is something that a group of us has built over the last, I would say, 5 to 6 years, and it's building on work that was going on for a much longer time. We have a project, we have a blog, and it started with a kind of manifesto. This was about 1 year after the Trump election in 2019. And part of what we argued in that manifesto was that we live in a world, I think, that is fairly characterized by a kind of multiple overlapping crises. So climate crisis, crises of inequality, structural racism, sort of hollowed out democracy. And that all of these can be connected to the way that our political economy works, the way we've thought about the relationship between our politics and the economy, and sort of holding politics and the economy apart, elevating a certain idea of market efficiency. If you think about the COVID moment when there was this sort of, we have to all get back to work because the economy is suffering, right? We should take really seriously questions about what the economy needs, but we should build an economy that we want to build, that actually works for us, as opposed to sort of imagining the economy sits out there as this thing that we have to, we have to sort of feed and take care of. And of course, law is a great place to work on questions of political economy. And the way I think about what political economy is asking questions about how does politics construct the economy and how does the economy impact politics. Now, even just to ask that question is to say there's no such thing as the market. There is no such thing as the economy. Now, as a lawyer, I'm in a great position to try to convince you of this because I teach classes like property law and contract law and antitrust law and banking. I don't teach banking law, but I do a unit on banking in my class on law and political economy. It's really interesting and important to understand, like, where does money come from and what are banks, right? So law, these things that we think of as the market, right, supply and demand, are actually built out of a whole series of choices. Like, do you have patents on medicines? Or, do you not? Do you instead have government funding that would, there's things to say about why we might be worried about government funding, whether that works well, and things to say about why we might be worried about patents and whether that works well. But there is no question but that we have made a choice to make the market and the price do a certain kind of thing by making a certain set of laws. And so part of what we're tracking in law and political economy is all kinds of changes that happen and that lawyers have an inside view on. And some of them are statutes that got passed, right, or treaties that got negotiated to, in fact, try to empower, largely one could think of it as empowering business and then disempowering, let's say, consumer protection laws or other kinds of, let's say, labor protections, things like that. So if you go on our blog, you'll find lots of very short and readable pieces about sort of like how did antitrust law change in the 80s and the 90s, and to enable what we've seen, which is a very powerful way of corporate consolidation and concentrated power. So the ways that hospitals have merged, the ways that the financial sector has consolidated, the ways that tech companies have consolidated, all of those things were sort of enabled by changes in the law of competition. In fact, those were very directly traced back to here because they're a big part of the law and economics movement. The first thing they took on was antitrust, and they really wanted to change antitrust law to enable more things like mergers and sort of vertical consolidation of industries, and they were very effective. So you'll see all kinds of other things that we talk about. The intellectual property law gets a lot stronger in this period. We, in various ways, either undermine forms of state, kind of the welfare state, or we just don't acknowledge and talk about it. So for example, there's a lot of NIH funding that goes into the industry, but we don't talk a lot about that. People have the conception that, we call the COVID vaccine the Moderna vaccine, even though the Moderna vaccine is built on a patent from the NIH, research from the NIH, and then we almost paid 100% of the research and development cost of that vaccine publicly, right? But we call it the Moderna vaccine and not the NIH vaccine. In the NIH, they call it the NIH Moderna vaccine. But they're the only ones that call it that because we don't appreciate it, right? There's a kind of submerged state. And that's, again, part of the sort of ideological construction that, well, the public sector can't really do anything very good, and the private sector is really where the generative, innovative stuff comes from. Okay, so we're broadly, and I guess I want to say there's an attempt sometimes or there's an instinct sometimes when we talk about the economy, and I've used a bunch of examples that are very classic economic stuff like antitrust and intellectual property, to sort of separate that from questions of care or the carceral state. One of the things we were trying to do is really resist that. And one reason to not think of this as a deregulatory period is that there's a lot of like carceral regulation that gets built out in this time, whether the, mass incarceration, borders that are militarized in this period. And so again, there's a kind of a way in which, there's a lot of work on those things too, even though they're not the center of what I want to talk about today. Okay, so broadly, we're trying to sort of challenge this status quo and these set of ideas that helped motivate some of these legal changes and that have been important to defending them from their critics. And so we're trying to sort of challenge this idea of a separate economy that can't be affected by policy. And also, so there's a sort of descriptive set of things, like how did these laws change? Like, how did the law of patents change? What is this WTO TRIPS agreement, right? How did law change in this period and to what effect? And so therefore, like how law is shaping political economy and how political economy is shaping law. But there's also a constructive element to it. So how can we actually figure out better ways, more democratic ways to build the things we need and diminish concentrated private power and build public power? And that, I think, is not only thinking about things like, the public production of medicines, which again, happy to talk more about, love to talk about that. So not just in the sense of like, the public should build and own more things. We all know that we can build public systems that deliver very poorly for people who are vulnerable. So we also have to think really deeply when we're trying to construct this better way to provide the things we need. How do we build more genuinely democratic and inclusive institutions? So those are all the kinds of things we're thinking about. So let me shift now to the sort of health and political economy questions that I think might be already, and I'm realizing I'm not a public health scholar or